Top Med Talk.
Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. Anesthesiology 2022, October the 21st till October the 25th in New Orleans. Anesthesiology 2022 is the largest gathering of anesthesiologists in the world. The American Society of Anesthesiologists annual general meeting. You must be there, and you can get exclusive access via ebpom.org. That's right, Evidence Based Perioperative Medicine. Check out live.ebpom.org for exclusive access to this incredible conference. That's live.ebpom.org. Enjoy the program.
All right, well, welcome back to EBPOM USA 2022, Optimizing Intraoperative Management. I'm Desiree Chappell. My co-host today is Monty.
Hey, Desiree. Great to be back out in the big bad world.
It is. Today we have Dr. Mark Koch. He is from Somnia. Mark, thank you so much for joining us.
Thank you, Desiree. I'm a board-certified anesthesiologist, and I look at medicine through that, but I also have an MBA in finance, and I look at it through that. And I'm a huge proponent of and believe in perioperative medicine. And thank you and Monty and Solomon and the many others who really have helped so many patients, so many clinicians, and countless facilities. So thank you.
And thank you for being an active participant in EBPOM over the years, for sure. Our other guest is Dr. Josh Lumbley. Josh, thank you for joining us. You're Chief Quality Officer of NorthStar Anesthesia, my colleague, actually, my partner in crime in that job with that hat on. Thanks for joining us. Josh, tell us a little bit more about you.
Yeah, I'm a practicing anesthesiologist from Columbus, Ohio. I'm NorthStar's Chief Quality Officer. So in that role, I oversee about 2,500 anesthesiologists and nurse anesthetists. Dream scenario, I'm helping them guide a patient through their whole surgical experience safely, comfortably, and ideally with no complications.
We'll come back to that one.
Yes. I underhand pitch for you.
Sotiris Rompas. Sotiris, thank you so much for joining us remotely. You are with Edwards Lifesciences. Tell us a little bit more about yourself.
Thank you, Desiree. It's great to be here, and I apologize for not being in person. I'm Sotiris Rompas. I am an economist by training, which sounds as boring as it sounds. And in my day job, I lead global health economics and reimbursement for Edwards Critical Care, and really my passion is making our technologies accessible to more patients. So thank you for including me in this amazing panel.
Absolutely. Well, thank you again for joining us remotely. I know it's a little tough. We got all of it working out. We wanted to start off the conversation today. Monty, I'm going to pitch that over to you.
Yeah, so I was going to dive straight into enhanced recovery after surgery. So we're about 30 years into enhanced recovery now. We're 10 years since we closed out in the United Kingdom the national rollout of enhanced recovery, and we can come back as to whether that's stuck or not. But what it did seem to deliver was the value proposition. It delivered quality, fewer complications, reduced length of stay, much happier patients, fewer readmits, and now it appears improved long-term care. So I'm assuming that everyone is doing it everywhere now. Who wants, Josh? Why don't you go first?
I agree with you. We do it everywhere, and we do it. It is rolled out 100%. Yeah, absolutely. Regrettably, we are not there. At least my experience is that we're not seeing it there. And the way I guess I liken it is the soft science associated with enhanced recovery has not caught up with the hard science. So we've sort of delivered the recipe for how to make the cake without teaching the person in the kitchen how to actually do the process. And so the soft science associated with change management, the soft science associated with having a leader on the ground who owns it, it's part of their portfolio, and kind of pushes it and drives it forward, that's been the heavy lift that, at least in my experience, has kept it from penetrating at all of our, at all of our clinical locations across the country.
Sotiris, looking at it from the health economic perspective, I know you've looked at this quite a lot with your team recently. Do you get the impression that enhanced recovery after surgery delivers the value proposition?
Thank you, Monty. It does, based on the studies we have, at least in the public domain. Enhanced recovery as an evidence pathway delivers between, let's say, $2,000 to $6,000 per patient per year savings, if you see it as a bundle. The majority of those savings are really driven by reduction of length of stay. We have now evidence that suggests that also enhanced recovery drives a lot less opioid use post-surgery, 20% reduction in one of the studies that I just found this morning. And I think it supports the overall value proposition. However, I don't think we have the right incentives in place, and I haven't really seen from a payer's perspective, an alternative payment model that bundles all this together and makes it more accessible to the health systems. But I think from an economics perspective, the savings, the evidence are there, at least as a total bundle, and mostly driven by length of stay reduction.
Thanks, Sotiris. Mark?
So I guess my comments are that, I guess for us, we have between about 750 clinicians out in the field, and I would say that at most of our facilities are doing some part of ERAS, one component or another. But a lot of times the results you get with ERAS is by following the protocol strictly, and the more elements that you're compliant with, the more closely you'll get those results. And I think that brings out an important point, because you have to be very careful with it. And just like with the beta blocker situation, now we're finding out like gabapentin, giving it to elderly folks who have problems could cause more problems than they solve. So if you're doing everything and that everything includes gabapentin, maybe not the best thing. And I think the savings are great, and that's fantastic economically, but we just have to take a look at longitudinal outcomes, 30, 60, 90, 180, even longer, to determine really what the overall net savings are, to make sure those hold out.
And in the transition that I've heard about from volume to value, me coming from a different healthcare system, are there any barriers that are put up by being on the wrong part of that pathway? In other words, that for some facilities, enhanced recovery might be delivering all those good things, but it's not making good business sense.
Jim, so your question is the cost to doing ERAS?
Yeah, and or it happens to be that the way that the particular type of facility in a particular type of place works, that reduced length of hospital stay is not necessarily a good thing, or reduced complications are not necessarily, just from a pure business sense. It's obviously good for the patient, but...
Yeah, I understand. So, not every place, not every payer is on a DRG basis. So if you get paid by the number of fill in the blank, procedures, days of stay, labs that you order, ancillary services you invoke, then having those head in the downward direction might not be financially beneficial to a hospital. So when you talk to a hospital, you have to always be very measured with it, or at least go into those conversations understanding what their payer mix looks like and what their underlying contracts look like. Realizing that in most hospitals, between 50 and 70% are Medicaid, Medicare. That's not true for every single hospital. And the savings you might get on the value side balanced against the savings you might lose, or the dollars you might lose in a non-DRG environment.
I think some of the barriers that we've seen along the way, this one in particular, has become a major issue for a lot of facilities and a lot of groups to really go forward with enhanced recovery. I think, to your point, when it comes to the DRG and just the payment model, I've seen places where they go to their CEO and their groups and say, oh, we're going to reduce ICU admission. Well, they just built, $116 million ICU. The last thing they want to do is reduce admission to ICU. So I think it's, those are some of the challenges. I think a lot of people believe that they're doing enhanced recovery in some form or fashion in many places. I just don't think that people understand the whole picture and how, the role that they play in it.
And where I go with it is less about the pushback from hospital administrators in terms of saying, well, we want these patients in the ICU, or we want inpatient stays. That takes money away by converting them from, long inpatient stays to shorter inpatient stays. It's actually, some of the topics that came up on earlier conversations of, is now the right time for us to be doing surgery on this patient? Or is there a way that we could delay this case, or maybe not even do this case, to prevent complications thereafter? Like that sort of conversation, I think a lot of hospital administrators and surgeons say, I want to do my total joint tomorrow, and even if this patient is anemic, we're doing it tomorrow. That's where it's booked. And so those sorts of conversations are problematic in current state for us.
So to share from the United Kingdom, perspective, from the NHS in England, which I think we were sort of poster child of a national rollout of enhanced recovery between 2008 and 2012. getting almost complete adoption in the country, we recently published a follow-up audit of where we are today. And the metric we chose was drink, eat, move after surgery. So in other words, as a surrogate measure, is the patient drinking, eating and mobilized within 24 hours of almost all forms of major inpatient surgery. And if they achieved that goal, we'll come back to who achieved it in a moment, it was associated with a 2-day reduction in length of stay and overall better outcomes. But if we divided the country by quartiles, and this is all published in the British Journal of Anaesthesia, tens of thousands of patients across the whole country, the lowest quartile had a 0 to 20% drink, eat, move rate. The top quartile, so 25% of the country, had an 80 to 100% drink, eat, move rate. So I'd say even us who thought we were poster children, we have slipped back for some reason that we need to try and understand. So Sotiris, any economic barriers you can share with us to adopting enhanced recovery?
Yeah, Monty, is a great question, and I certainly don't think I have the answer, but I will say that we have enough evidence. If you look at the big Alberta study in Canada, that's back in 2016, thousands of patients in colorectal surgery across the Alberta Health Service, which is a big regional system, taking a health system perspective, showing, $3,000 Canadian dollars back in 2015 savings, much less healthcare resource utilization, etc. But I think for me, it's a question of incentives, because I think to Mark's point, reducing length of stay, reducing ICU length of stay might not be the only or the most appropriate economic outcome. And so the question is, how do we create a win-win for the payer and the health system? And one hypothesis, at least for me, is that because of some of these enhanced recovery protocols are complicated and compliance is hard to be achieved in all the 30 elements, do we know what the relative economic value of each of these components are? In other words, if I carb load the patient or I do, certain things before in the preoperative setting, does that have the same economic and value and outcomes value, let's say something like hemodynamic management intraoperatively?
Sotiris, help us here. Reducing complications, is there any world in which reducing complications isn't anything other than a win-win-win? What am I missing here?
From a patient's perspective, Monty, 100%, but let's keep in mind, to the opening remark of we're still in a fee-for-service environment. It depends how you're contracted in the United States, how you're contracted as a health system with a payer. So if we have aligned incentives and we're sharing the savings out of reducing that complications and length of stay, then yes. But in a pure fee-for-service environment, reducing ICU length of stay might actually be detrimental to the top line of the hospital. So from a patient's perspective, you're absolutely right, but it requires a move toward alignment on incentives, on outcomes and quality from a payer and provider perspective. That's true mostly in the US, where you have regional systems that are truly integrated and you have payers essentially owning the care delivery network. In those circumstances, yes, as long as the contracts are based on quality and outcomes and not necessarily just on volume of work.
So I'm going to pick on the two major components of enhanced recovery in the operating room that we as team anesthesia and the team wrapped around the surgeon and the patient are said to have the greatest influence on what happens next. And that is pain management, how we deliver analgesia, and hemodynamic management, so how we manage blood pressure, fluids, etc., etc. So starting with pain management, the opioid crisis and some of the difficult messages we've had to share with each other, including some of the recent guidelines and roundtables that have concluded that about 10% of opioid naive individuals who go for surgery end up being addicted to opioids, and whether it is true related or true unrelated, the finger in part has been pointed at us. Mark, would you like to comment on that?
Sure. So, I think when you talk about, pain management, that, a lot of times we think about blocks, and I think it's much more than blocks. It's understanding the full toolbox of things we could bring to the table to help patients, some of which are pharmacologic, some of which are physical, some of which are nutrition and so forth. And what I've seen in the people I work with is that there's a larger, much larger footprint put on the blocks. When I've asked clinicians about what is your approach to acute pain, the first thing they say is blocks. Mm-hmm. And if I say to them, well, do you use anything with regard to sleep or antidepressants and oral medications, they usually say, no, we do blocks. So I think it's an appreciation about the broader world out there, about the things we could bring to help patients. And I think that begins preoperatively. You have to see patients in the clinic, spend time with them, explain to them the pharmacologic, non-pharmacologic, interventional, non-interventional approaches so that they're primed and ready to be partners with us in approaching their post-op pain.
And is the attempt to reduce the amount of opioids we use and give our patients at the end of surgery, has everyone taken that very seriously now? Do you think that is a common goal?
Everybody I've met recently it's one of the first things they mention.
Yeah, and I think this is one area that I think you see surgeons, you see hospital administration, you see nursing staff, and you see the Department of Anesthesia aligning around that, about doing an opiate-sparing technique for your patient. One other thing I would just add, my experience also, Mark, has been that there is a ton of perseveration on regional anesthesia. I do find that, amongst a lot of my anesthesiologists, nurse anesthetist colleagues, there's a great deal of professional and personal satisfaction being able to do that. The tactile response and seeing the almost immediate gratification associated with it. For us at NorthStar, it has been kind of like a launching point of saying there's yes and, hey, this is just one part of the larger picture of that we need to incorporate to really build this program out from a multimodal standpoint.
But you think everyone's bought in? The ambition, the goal?
I think we're probably 90% there, 95. It is uniformly. This is the first step that everybody goes in their journey, on the ERAS journey. Because I think there is some technical component to it. Now they may not have built out the entire pharmacologic regimen there, but I think we are there.
I think they're bought into multimodal. I think the opioid thread has been out there for a long time now, or at least the last 5 years. Yep. And so opioid reduction has been pushed to the world of anesthesia. So I think a lot of people, if they're not all in, they're definitely exploring at this point. I think actually there is even some drift in the message of enhanced recovery. A lot of people think because they are just doing regional,
absolutely.
I'm doing a block, I'm doing ERAS. Not even I'm doing a multimodal approach to acute pain management. I'm doing a block, so I'm doing ERAS. And so I think that that's getting a little bit confusing in the space as well.
Agreed.
And blocks being not epidurals, if you see what I mean, more because
that's right.
That's regional anesthesia, peripheral nerve blocks, and even in some certain instances, spinals, epidurals for different procedures. But
very selective. Because one thing we did identify on our follow-up once again is the use of an epidural is associated with prolongation of length of stay and a much greater likelihood of not achieving drink, eat, move. The other blocks seem to help a lot, but the epidural and everything that goes with it, unless it's very specifically targeted at somebody with respiratory challenges who's going to a high care environment, seems to be a hindrance rather than a help.
I think we also have to be careful about going entirely the other direction. Because if patients have an open belly case, thoracotomy, they have a big surgery, they might need the narcotics. And if we don't give it to them and we create a lot of encumbrances to them getting it, they'll go to their next door neighbor, the person in the apartment over, and they're going to find some way to address it. And then we lose command and control of that episode of care and the pain management they're in. And if we are still involved and advocates for the appropriate, when necessary, use of narcotics and bring a lot of education and knowledge to bear to teach them, I think you might start to see that 10% shrinks. I wonder if that 10% you spoke of were patients that might not have had access to a physician or a CRNA or other professional for their narcotic management. Because narcotics aren't bad if we use them in a smart, appropriate way.
And Sotiris, I'm hearing here that there's sort of general cultural, clinical buy-in, maybe not total, but it's been a reasonably well accepted, quite a success. Health economically, does it stack up as an ambition, or is it just an easy sell because the story's so compelling?
great question, Monty. I think we have enough evidence that opioid-free anesthesia drives reduction in opioid use post-surgical in the post-surgical world. I don't think we have great evidence, economic evidence on the longitudinal effect because a lot of these studies are just very short in that sense. But I think we have good signals. I think that the challenge that I have from an economics perspective is the variability of how enhanced recovery is implemented today. And to Mark's point, how do you take a personalized approach to enhanced recovery because not every patient is the same? And how do you put all this stuff together to show longitudinal economic effect back to the payer? But we do have evidence. I mean, there is the Level 2020 SLR that shows that a lot of the association between how opioid naive patients become opioid dependent after surgery, and then obviously the enhanced recovery literature covers very well the economic benefit of opioid-free anesthesia, both from an economics perspective, but also from a patient perspective. So, but I don't think we have good longitudinal economic evidence to show back to the health system the relative impact, given the crisis with opioids.
And I think, Josh, you turned on it. It sort of appeals to us as anesthesia providers as well. It's a challenge we sort of understand and we quite like, and possibly you can learn a block, you can get a new syringe out, so it's okay from that perspective.
Yeah, it is. I mean, I think they're also, like geeking out on anesthesia for a moment. I think that's part of the reason that a lot of people went into the specialty of, wow, today I'm going to learn closed circuit anesthesia. This is going to be great. I'm going to calculate, what the minimum consumption of oxygen is in this patient on this case. This will be exciting. And I think that constant learning, I think, is what attracted people to the specialty. And so being able to, change your techniques and adapt over one's career, but also just learning something new is exciting for folks, and it's why a lot of us chose the specialty to begin with.
And if I may, just really quickly, it's the instant gratification. We were talking about that earlier of anesthesia, because we don't get a lot of that. We don't, we drop our patient off, they look great. We don't still see, but you instantly see whenever you do a block after surgery, like patients aren't in pain. They are happy, they're doing really most of the time. And so I feel like that's a huge driver for a lot of providers and clinicians that I know.
But when we did some of the guidelines, this is a recurring theme. It's interesting to note that, for example, consider using a gabapentinoid. Level of recommendation strong, evidence E. So there's a mismatch there. So so let's pivot then to another potential area of instant gratification. And that is hemodynamic management. And in the last few years, we've been hearing about intraoperative hypotension being harmful. Now people have been able to look at very large databases. They found associations between low mean arterial pressures and some quite scary outcomes. Now, Josh, Desiree, you've been involved recently in looking at some of your own data to look at the incidence. And we'll come back in a moment to say whether it's true related or true unrelated. These are associations we're discussing here. What did you find when you looked?
Well, what we found was that it occurs. It occurs like almost in 30% of our cases, and that it is surprisingly common actually in our ambulatory surgery centers.
So as you express the magnitude of the look that you did, Desiree, you presented it in London recently. How big was the study and who did you partner with?
So we partnered with USAP, one of the other larger national anesthesia companies in the U.S., and it was about a rate of about 30% in about 130,000 patients. So it wasn't small. Right. It was a large patient population that was dispersed among inpatient, outpatient, and ambulatory surgery centers. It matched up with the MIPS measure, the EPREOP 31, which is the IOH measure. And so we basically followed all the parameters for that, and that's how we determined our amount of IOH.
And remind us of that parameter. So a fail, if you see what I mean, is what?
Yeah, a mean arterial pressure of less than 65 for greater than 15 minutes.
So greater than 15 minutes of a MAP below the level of 65 in about 30% of cases.
That's correct.
Is that right?
Yep. And community hospitals, ASCs, large tertiary care centers, everything in between.
Irrespective of age, ASA, age of the provider, whatever it is. So it's a democratized...
It is.
Yeah.
Mm-hmm.
And there were, before that, the people were suggesting the fact that it didn't happen in shorter cases or smaller cases.
Yeah.
Correct.
There's an argument.
Low risk, I mean, it was in low risk patients, high risk, I mean, it happened across the board.
Yep.
Mark, do you think it matters?
I think it's the hard question.
Whether hypotension matters or not?
Yeah.
Of course it matters, yeah.
Okay.
Yeah, for sure. You know, it matters a lot, you know, and I think, you know, unfortunately for a lot of people that trained in the 90s, early 2000s, the sort of railroad tracks, you know, sign really is how we were trained to say that's a really great anesthetic. Well, maybe not so great.
Yep.
And, you know, a lot of people, because the workforce in anesthesia is aged and people are working later and longer in their career, a big proportion of anesthesiologists are older and practice with that mindset as a proportion. And it's hard to get everybody to be thoughtful and considerate of what the latest data shows concerning keeping the MAP above 65. And if you need to go lower for a very short period of time, it's not easy.
Yeah.
Sotiris, any intraoperative hypotension health economics?
So, Monty, there's a lot of evidence to suggest that intraoperative hypotension correlates with extended length of stay, extended ICU length of stay. One of the interesting things that happened in the policy environment in the US that happened a few months ago, OIG came out with the latest report, and they have a very interesting patient story identifying intraoperative hypotension as one of the top 5 harms associated with surgery in the United States. And they go and tell a story of an 81-year-old patient that had about a narrow hypotension, which is a lifetime based on the definition that Desiree just gave us. And that 1 hour of hypotension cost that hospital $50,000, which was reimbursed by CMS, but it nevertheless cost the system $50,000. So I think we're seeing a lot more movement, even in the policy space, with intraoperative hypotension, and I think the economics are going to get stronger as the time goes by, and we're trying to understand at the patient level what the economic impact is of intraoperative hypotension. But we have, I think, enough evidence now to know that intraoperative hypotension is associated with extended healthcare resource utilization. Recently published a paper on that, but also the latest data from the OIG. I think it's eye-opening to all of us and puts a spotlight on intraoperative hypotension, especially from a policy perspective.
Now, I'll bring the audience in a few minutes' time to comment on all the things we've been discussing, but I just want to finish this one off by, Josh, what would be more gratifying, instantly gratifying, than keeping the blood pressure up? I mean, even the pain-relieving bit, you know, that's not as gratifying.
Hello?
Nothing.
Okay.
And I think it really, I have to confess, I think it goes a lot to, to Mark's point, of this idea of like, vasodilation. It happens in anesthesia. I mean, come on, let's not go willy-nilly and start making up neo-drips anytime you see a MAP below 65 and, just chill. It's good, and that is, I think we're finding that ideology needs to just be totally turned on its head.
So your study you're referring to, the manuscripts under preparation at the moment, the preliminary results were presented at the World Congress. There's a session at the ASA, and a 1 hour session about it because it's real world evidence. But we're going to, because no one's listening, so we're going to give away the punchline now, okay? Mm-hmm. What was the biggest independent determinant of the hypotension?
It was provider. It was the clinician.
Yeah.
And the spectrum of having intraoperative hypotension and no intraoperative hypotension, how extreme was it? So some had nearly none and some had lots?
Yeah. And the lots was on, there was a lot with our ASC patients. So
how are you going to handle that, Desiree?
Good question, because that's kind of going to be our job. I think One, it's just getting this data in the hands of our providers to show whether we know it's a problem, but that this is what it is. It is what it is, and this is something that we need to address. I think we want to take kind of an approach where we do education, we look at different ways to see what works the best for our providers to improve hemodynamic stability. We have to look at this from all different angles.
Yeah. And again, I don't think it's naive to say most of the vast majority of our clinicians want to do the right thing.
They do.
There will be a small handful that will say, so what? Show me, what does it mean on this 21-year-old that I'm doing an ankle case on and has hypotension? Show me how many nephrons are knocked off. That's going to be the minority. The vast majority of people are going to go, okay, well, I need to do this.
Something.
So before you come in on that, Mark, the fear, though, is that we say, okay, let's start a phenylephrine infusion.
Yes.
So this is why I said a hemodynamic stability and not just treating IOH.
Yeah, because we've already seen a couple of publications, one relatively small, saying that they took the blood pressure away, but the phenylephrine went up and the kidneys went down. We've now seen a very large study from MPOG, the Multi-Center Perioperative Outcomes Group in the USA, published in the British Journal of Anesthesia recently, 5-year look, and hypotension's got less and less, fluid volumes have gone down and down, norepinephrine equivalents have gone up and up, and AKI's gone up, not down.
And in MPOG, the information that they got back was just their amount of hypotension that they had as a provider. So they didn't have any other information about the case.
So you've got to connect the two. It's got to be no IOH, no AKI, or whatever it is. It can't be just no IOH. Right. That would be like saying no opioids pain, wouldn't it?
Right.
Yeah. Or too much pain relief, no breathing.
Exactly.
Yeah. So, Mark, last comment before we bring the.
Sure. I think part of it is putting a spotlight on it. So we made brain health a big issue, right? Delirium, Beer's criteria, trying to really make that an issue. Narcotics an issue, right? I think if this became sort of an issue that was prevalent with stickers here and lectures being given, I think you'd have a big Hawthorne effect of just getting people unconsciously buying into this concept. And that was my last comment to underscore what everybody else has said.
Bobby Jean, if you could reintroduce yourself to the world.
I need to do that? I'm Bobby Jean Schweitzer. I'm a board-certified internist and anesthesiologist. I practice in Northern Virginia. You talked about the provider being the key determinant of the hypotension, and then we talked about phenylephrine and all that and fluid. Well, what about too much anesthesia? I think there's, accumulating evidence, right, that the reason the provider is the problem too is not only not maybe recognizing it or recognizing the importance of it or treating it, is not treating the right way.
Agreed.
I don't think too much propofol and too much opioids and too much, inhalational gas should be treated with phenylephrine.
Yep.
And we know from other data, and I know it's not perfectly clear yet, that the treating the hypotension, the best way to treat the hypotension will avoid the complications we are seeing with hypotension. But we do know from other studies, right, that low BIS and low, blood pressures and high, MAC or high levels of anesthetics altogether result in worse outcome. I think that's another key thing, is we need to just train people to stop wasting drugs.
I totally agree with you, 100%. And this is purely hypothetical, but I would imagine a incredibly large component of what we are seeing in this 30% is less under resuscitation and is more crank that gas up as high as we can possibly get it. And, this is what the patient's BIS is, so I'm going to go for that 2.2 of SIVO and let's roll. And I think you're spot on.
I think there are a lot of cases that we do now, especially I'm come from spine, working at Spine Institute. I know one of our CRNAs who works there too. We're not using any paralytic for a lot of our cases. And so, you have to run patients super deep, and you have to. I think that's been our perception. And I think that's what a lot of perception is. I must have this patient deeply anesthetized for this procedure. I don't. There are a lot of people who still don't use BIS, not necessarily in with our cases, but generally. So they don't really know the depth that they're running. And I think that most people who have kind of really dove into it find that they use less and less anesthetic gas, and they achieve the better results.
Dr. Aronson's got a comment or question?
I think this is a really important topic. If I were to ask us to think about it in a broader context, I think we've always wanted to do the right thing. Everybody's smart, everybody's well-intended, everybody's good. But what we've grown to appreciate better recently is where those guardrails are that we can accept as tolerable. I think for those of us who grew up in my generation, those guardrails are probably too broad, albeit for treating pain with opioids. And now we have a more narrow guardrail of acceptance for accepting hemodynamic parameters. It's always been a complex physiology. Taking care of patients is multifactorial, giving anesthesia is complex. All the variables that roll up to that are still the same variables, but our tolerance for where those bookends of guardrails are, I think, is becoming a little tighter and more sophisticated, and I think that's a good thing. But the questions have not changed in terms of how we should address the causality and what our approach should be. But we just can't be as tolerant. Yeah. Look, when I grew up, yes, a low blood pressure was likely to happen because of all the, pharmacologic consequences of the drugs that we gave, including the anesthetics directly. But gosh, the CMRO2 went down and the oxygen consumption went down, so it was okay. And we're now beginning to have a little bit more sophisticated reality where those critical perfusion pressure, tipping points are. And I think that's where we are now today.
Yeah. So if we give too much opioid analgesia, for example, if we leave the patient in pain, if we're sloppy with our fluid management, if we're sloppy with our blood pressure management rather than sophisticated, and we know the evidence is clear that sophisticated hemodynamic management, for example, is associated with much, much better outcomes, is that part of the challenge is that we're not owning those complications. So in other words, the complications get typically assigned to the surgeon or possibly the institution. Whereas if we caused a bunch of them, why aren't we owning them? Silence.
It's really hard to own something that you don't know about.
Yeah, I tend to kind of go that direction as well, which is...
Shouldn't you know about it?
We should. And I think that's where people like the three of us come in terms of making sure our colleague clinicians are well aware of, I don't want to say, let's say consequences. The consequences, the downstream effects of what happens during this 90-minute procedure. And our specialty societies can also say, this needs to be like the point for the year of, we need to make sure that all of our clinicians are well aware of the effects of this issue specifically.
Because isn't that the value proposition for the service that you provide, is sophisticated pain and fluid and hemodynamic management? And if you don't think it makes a difference, can we talk about a different pricing structure? Because you've got to own it.
Yeah.
Sotiris, can you comment on that? Because one of the challenges with bringing some of these potential technologies that may help to bear is it's not often clear or accepted that some of these things make a difference, and it's not clear who's owning them.
Yeah, thank you, Monty. And I don't think I'm going to tell Josh to do value-based contracting anytime soon, but I think that there are two elements here. We always knew in diabetes that time in target and A1C is a very simple thing to measure. But we've never had patient-level data, glycemic data, sophisticated enough to do so. So a lot of these value-based arrangements, if you like, depend on the fact of having access to the right data at the right time. And fortunately, now we have technology that allows us to be more sophisticated with hemodynamic management, but I think we're still lacking the data infrastructure to allow, organizations like NorthStar and health systems and payers to really develop these triple wins to understand how the provider level viability might drive better economic outcomes, better quality, the quadruple aim. But I think we're lacking the data. And I think the sophisticated hemodynamic data at the patient level and at the provider level will probably allow us to do so and take more ownership of the outcome.
Because I assume that you compete with USAP and you compete with Mark and his group to try and secure contracts, and I'm assuming in negotiating, you negotiate on value.
Yeah, but if you go back and relate that to the, why don't we own it? Is that's a conscious choice. Okay. We decide whether we're going to see that patient post-op day 0, 1, 2, 3, 4. Mm-hmm. And if somebody said, well, how do we know? Well, it's a decision for us why we don't know, right? So it's that level of engagement. I think it puts a big distinction between perioperative medicine and anesthesia, right? If you're an anesthesiologist, thoughtfully and really great at what you do, but we see the patient, we round on them post-op day 1, and that's it. But when you take a look at perioperative clinicians who follow that patient more longitudinally and see them post-op day 1 through 3, they might check in on them in post-acute recovery. They might involve and engage some of the consultants that care for them routinely. Now you're kind of in the thick of it, and you have that awareness, and you can own it, right? So part of what I guess my personal belief is that, we choose the level of engagement we want, and we get the sort of involvement that we get because of that.
And do you risk share, Mark, or do you risk share just by the nature of the fact that you're a good partner with the people that you work with, and therefore by default it may not be a contractual sharing of the upside and the downside, but it's
not contractual, it's collegial. And when you're around or you're talking with your surgeon or the patient or the nurses, and the patient has delirium, I bet you those discussions in the hallway, sometimes there's no anesthesiologist there, right? Talking about, hey, this is what they got. I think it could be this. It could be that. We're not there a lot of times. And I think that's sort of, again, to me, draws a distinction between perioperative medicine and anesthesia.
Yeah. The one variable here that I really think is important to raise, and I don't know if the theme was going there, but I want to put a stop sign so it does not go there. These concepts that we're talking about are greater knowledge today than it was 10 or 20 years ago is great. And what we should be talking to each other about are facts, not faults. Patients will get hypotensive. Patients will have pain. We are working in a very complex physiologic, biologic system that we induce these terrible perturbations for. So stuff will happen. That's a fact. What we know now, we didn't know yesterday. And so our guardrails should be more sophisticated, and we should embrace tools that will enable us to be better. And we should address the fact that a patient will get hypotensive, and we should address the fact that a patient will have pain as best we can, but it's not our fault. And so in terms of the question of ownership, whether or not we should be spanked or whether or not we should be rewarded, I don't know that that's the right answer. I think about the opioid crisis real quickly. We've done a really good job when we illuminated the crisis as the opioid endemic, and we're not prescribing 30 or 60 pills anymore. We're prescribing 3 because we know and I think we have to illuminate the whole hemodynamic issue as well so that we can behave better, because that's a fact. And it's not anybody's fault that a patient will get hypotensive. We just need to know what that means and how we define it.
Hey, this is Chris. I had a quick question. It seems like some of the big factor for why anesthesiologists may not buy into this is because from a timeliness standpoint, you mentioned when they're hypotensive for 15 minutes, we don't immediately see something. It's obviously a delayed response, and B, it's uncertain. Maybe they'll develop something, maybe they don't. And we were talking in the break about smoking. When people smoke, they immediately and always get a nicotine high, as opposed to they might get cancer down the road. So it's not as much a deterrent because it's uncertain and it's not timely. Is there a way managing this that intraoperative hypotension could have an immediate response for providers and a certain response to providers, and do you think that would influence behavior? I'm
just going to throw something in down the last few minutes, because we saw launched in the European Parliament last year a document launched in the European Parliament by 2 MEPs. The document was written between patients, providers, and a broader group, surgeons, anesthesiologists. And the patient representatives, when they heard the intraoperative hypotension story, they said, we understand you can't be certain about causality here, but you seem to be telling me that having a low blood pressure, which we understand, is very common. And if it happens, I might have had a silent injury to my kidneys, and I might have had a silent heart attack. Don't you think you should tell me that? That just seems reasonable. That if that happens, please just come to me afterwards and say, despite our best efforts, you had this risk factor, and it's really important that you follow up with your general practitioner in a few months' time to make sure you don't have an elevated creatinine and protein in your urine. Do you think that would increase the immediate gratification?
Yes.
Are we ready to go there? That's the challenge to them in Europe, and they're thinking about seriously saying that is a duty of candor to share that.
In the U.S., are we ready to go there?
Yeah.
No.
Okay.
So, gosh, that's too bad. And let me sort of spin that real quickly to be a marketing, if you will, branding kind of positioning. Patients now are calling their surgeon or their institution, and they're choosing their surgeon or their institution based on whether or not they have a robot. And it sticks. It's a marketing, if you will, reality. I'm not even speaking to the data that is a whole nother conversation, but it's reached the consumer at that level. Why are we not asking or teaching our patients to call an institution or their physician to understand whether or not they do ERAS, or to understand whether or not they're using the latest and greatest tools to enable the prevention of these, markers of badness? How do we go directly to the consumer to enable them to be a part of this equation of motivating behavior change?
I think it's a good question. I think working, with our hospital partners from an anesthesia perspective, working with our hospital partners to share that, for instance, we've come in, we're helping you do enhanced recovery, we're doing enhanced recovery as a whole, let's market that to, the potential patient or our patients. I think is one way really to get at that. I think part of the problem with why we're not ready is that we're not ready to take ownership for it, back to your question. Because we're not for sure we know that we may play a part in this. A lot of people will say, well, is it the intraop hypotension or did something happen afterwards? There's a lot of variation in all this, and there's a lot of still a lot of questions about it. So until we're ready to take ownership of the hypotension and the negative effects with it, you're not going to get people buying in saying, yes, we should really talk to the patient about it. I mean, that's my perspective. Now, is that what I agree with and believe in? No, personally, but I do think that's an issue.
Sotiris?
Well, to Chris's point, question before, I think we do have technologies that allow us to at least try to predict hypotension. So, one of the questions that I always think about, given my role, is what's the role of technology here in terms of helping us to do more sophisticated hemodynamic management and know more and even help the patient. Saul's point around the patient education is a really important one, and certainly with Edwards, we touch 15 million patients. We think constantly, how do we educate them better? Just for the group, and maybe some of you have seen this, but there are health systems out there that actually have created public material to educate patients and enhance recovery. HCA recently published an enhanced surgical recovery pamphlet that explains the benefits, but I think we need to do a lot more. And bringing the patient to the dialogue, I think it's going to be very, very important.
Mark?
So I guess, I think one of the things is that I think what Saul said and what Chris said and what you said was, that we don't have a way to sort of see what the immediate causality is here. Is there going to come a day when we could see, okay, well, we're not talking about hypotension, we're talking about cardiac output and perfusion, and we're talking about end organ perfusion. And if the kidneys are being harmed, do we see release of NGAL? If the liver's being harmed, do we see LFTs bumping? If we see that the heart's being harmed, do we see troponins? And is there a way to one day get this information real time so that people could see almost immediately what they're doing and how it's hurting the patient? Because right now, from end organ damage to what you're doing in the OR, those things are just, there's a lot of stuff that happens between there.
I think one of the biggest challenges with that is that when something happens to someone outside the hospital, we assign a diagnosis to it. When something happens to them inside the hospital, we don't. If someone gets dehydrated and comes into the ED, they're diagnosed with dehydration. If we dehydrate them, they're not. If someone gets hypotensive because they took an opiate outside, they're given a diagnosis. If we cause them to be hypotensive because we gave them an opioid, they don't. We actually have to start finding a way to capture iatrogenic diagnoses better, and then we can follow it.
And Alan, the term hospital acquired, because I've seen that creep in some places about hospital acquired acute kidney injury and hospital acquired acute kidney disease. Does the hospital acquired label go part way to that?
That would help. I mean, and how it gets assigned, when they leave with a higher creatinine than they came in with, and there's some amorphous thing that happened that somehow going through the air of the hospital gave them a higher creatinine. But we have to be better at being just more upfront about what we have done. And I think in the United States, we're paranoid about the litigation involved, but I think we use that as an excuse for our own insecurities more than anything else.
Yeah, see, the interesting thing about the should that document launched in Europe have those statements in it, was the legal advice was you're in a much stronger position if you just say that we did our very best and despite our best efforts, you had something that is common, which is called hypotension, and please keep an eye on it.
Yeah, well, how these things are rolled out, yeah. I mean, without accusation, but in the recognizing that people have a lot of variabilities that are unmapped, there would be a way to do this, but it's a cultural change.
Great. Well, on that comment, we're going to take a break in a moment, and when we come back, we're going to be going into the post-operative period. So I'd just like to say to Desiree, could you close the session, please? Put your Top Med Talk EBPOM hat back on.
That's right. Yeah, I know. Change hats here. 1 second. Well, thanks, everyone, for participating. Josh, Mark, thank you so much, as always, for joining our panel. And Sotiris, of course, thank you for joining us from afar. We really appreciate it. Great questions, great commentary. We hope to continue this conversation. It is not the end. I really feel, and we all feel like this, it's still in the beginning stages. So thanks to everyone. Stick around for the next session. Thanks.
Perfect. Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.